Good afternoon and welcome. I'm going to start with just a few housekeeping items. The CME code for this presentation, this Wednesday afternoon lecture series, is 50121. And if you're watching on videocast and want to submit a question for the speaker, please use the Send Live Feedback button on the videocast, and that will send your question. It is my great honor to introduce Dr. Deborah Mosher. Dr. Mosher is Professor and Linda C. Gill Endowed Chair of Nursing, as well as the Assistant Dean of the PhD program and Scholarly Affairs at the University of Kentucky. Dr. Mosher is the Director of the Research and Interventions for Cardiovascular Health, or RICH, heart program. And her research really has focused on individuals with vulnerable cardiovascular conditions, as well as those in those rural populations and their caregivers, in order to improve health and to advance health equity. Dr. Mosher holds a master's in nursing and a doctorate of nursing science from the University of California at Los Angeles. She has earned many honors and awards, and if I gave them all to you, we would be listening to that for this whole period. I will point out just a couple of them. One, she has been the American Heart Association Kathleen Dracup Mentorship Lecturer, and she is in the International Nursing Researcher Hall of Fame, which is sponsored by Sigma Theta Tau, which is the International Nursing Research Society. One more reminder, the CME code is 50121, and if you want to send a question, please use the Send Live Feedback button. And with that, I'm delighted to introduce Dr. Mosher.
Thanks very much, Karen. I really appreciate that introduction, and I've been having a great visit, been able to see all kinds of people and see the clinical center. I've never seen it before. It's always been this mysterious place that a lot of nurses think about and maybe coming to, maybe work there, so it was delightful, and everybody has been so wonderful to me. I am going to be talking about my favorite topic, cardiovascular health disease disparities, cardiovascular disease disparities in rural America. And I titled it, Can This House of Cards Be Saved? And hopefully you'll see why I have that viewpoint. My email address is on here. Please feel free to email me with any questions, and I'm happy to share my slides with anybody. I need to always start with some acknowledgments. First off, the community members who are really important, obviously, to this research and who have been so engaged and have made it so successful. There's a Center for Excellence in Rural Health in Hazard, Kentucky, in Appalachia, that we work with really closely. Great funding from the National Institutes of Health. Also great funding from Patient-Centered Outcomes Research Institute and HRSA. And finally, the Rich Heart team is the team that I direct and that does all this research. We've really developed this amazing team with, complementary expertises and have really done some amazing research. And I couldn't do anything I do without them. Since I'm talking about rurality, I'll start by defining it. And I thought, okay, I'll just look this up and I'll see how easy it is. Well, it's not that easy because there are so many definitions of rurality. I sort of love the CDC definition. Define urban and then everything else is rural. That's a good one. Ultimately, you can take a look at these, but ultimately we found the rural-urban continuum codes to be the most helpful for us. You can easily look up somebody's address if they have one. Sometimes rural people have unusual addresses, but you can, if that's the case, you can usually figure out that they're rural. And it differentiates counties based on the population size and its adjacency to metro areas. And there are 9 codes, and we use anything greater than or equal to 4 as rural. It's important to know that in the United States, about 60 million people live in rural areas. That's 20% of the U.S. population. And we define rural as a town of less than 2,500, a metropolitan center of less than 50,000, or open country. And a lot of the people that we work with in Appalachia live in open country. And I've just listed a few names here. I love some of the names that rural cities are given. Bug Tussle is in Monroe County, Kentucky, and it actually has that name. It has about 376 people. There's only 11,000 people in the county, and it has that name because it's notorious for these flying bugs that, are so prolific and are around at certain types of the year, summertime, late spring, summertime, that they just sort of, are smashing into each other, smashing into everybody. So they named the town Bug Tussle. It's interesting to note its median individual income is about $25,000 a year. Manchester is another county, or another city in Clay County in Kentucky. It has about 1,255 people. Its median individual income is less than $15,000 a year. And at any given time, it's received this name or this distinction of being the poorest county in the entire United States. Other counties will fight with you over this. They want to be the poorest county, but it has been in and out of that category for a long time. 42% of the people in that town live in poverty. It's also been named the fattest county in America, and Manchester the fattest town. So people from that town are really sort of tired of being the fattest, the poorest, the most with diabetes, and I'll talk about some of the reactions people have to these names that they get. Hazard is a town in Perry County. It's about 5,000 people. It has a low individual median income, and it's really distinctive in that county, that single county, has the worst life expectancy of any county in the United States, and it's maintained that distinction for a while. So you can begin to see that we have some serious disparities, and a lot of these are related, as you'll see, to cardiovascular health. And just so you get some reference point, the median individual income in 2021 was $60,000 in the United States in general, so only 13% of people living in poverty, compared to every county in Appalachia has a poverty level that's above 35%. The highest, I think, is about 47%. And I give you this great picture of dwarf Kentucky. So there's a lot about rural areas that are so charming and so pleasing to people. People in all these rural areas are really proud of their areas, but they need help, and they recognize the need for help to address some of the serious disparities that exist there. As I know you all know, the mortality from cardiovascular disease is not homogeneous across the United States. And you can see the area in the red circle is the area that I'm going to concentrate on. We see disparities throughout rural compared to urban, but my biggest area of research is in Appalachian, Kentucky, so I'm going to concentrate on that, although I've worked in rural counties in California. Every time I say that, no one thinks there's a rural inch in California. But in fact, there are some very extensive farming and ranch communities that remain very rural, and also in Nevada. And you can see from this slide, the very high rates in the red are the highest rates of deaths. And you can see these few areas that are really kind of characterized by Appalachia, but also the heart and stroke belt. Another thing to note about this area are that there are changes in life expectancy. There are 13 U.S. counties that have experienced declines in life expectancy since 1980. All of them are rural, and 8 of those counties are in Appalachian, Kentucky. So you can see a real concentration of severe disparities in Appalachia. And you can see these dark colors. The change in life expectancy to the left is a decrease. And every place else that it's not red or that it's not actually red and orange is an increase or a maintenance. This is a picture of Appalachia, you can see, and there are 80, let's see, oh, whoops, I wanted to point out this area in light is considered central Appalachia. It is considered the least healthy of all the Appalachian areas. It's in the top 1% of cardiovascular disease morbidity and mortality. It has the highest rates of multiple cardiovascular disease risk factors, including obesity, diabetes, physical disability, physical inactivity, smoking, Multiple CVD risk factors are present in the highest rates in a few counties in Appalachia, Kentucky, the central Appalachian area, and are higher than any other place in the United States. The heart disease mortality rate is about 42% higher than the national rate, and 80 of this subregion of 82 counties in central Appalachia have heart disease mortality rates that are higher than the national rates, almost everybody in this area. And we begin to see some of the source of some of these problems when we see that heart disease mortality rates in distressed counties is 29% higher than the rate for non-distressed. And distressed and non-distressed is a distinction given to Appalachian counties that are distressed socioeconomically with regard to jobs, income, rates of disability, but largely income. And so a county can be distressed, not distressed, marginal distress, moving into distress, moving back from distressed. They spend a lot of time making these distinctions, but the more distressed, the worse cardiovascular disease rates. This is a great slide that demonstrates the change or the divergence of life expectancy. You can see up here. Whoa! Oh, if I quit playing with this thing, you could see it. I knew I shouldn't play with it. I'll do it right this way. There it is. You can see when this started, urban and rural mortality was very similar. But around in the 1980s, late 1980s, 1990s, there was quite a divergence. And you can see that the greatest mortality is in rural counties. And that's controlling for a lot of factors like race, income, education, actual poverty levels, and rural residents were, so controlling for those things. And then rural residents was regressed on the age-adjusted mortality. And this distinction has carried out. This slide only goes to 2016, but in fact, it's a diverging problem. So unfortunately, these rural-urban health disparities have increased over time. Those in rural areas have poorer health, more psychological distress, more disability, and less physical activity compared to their urban counterparts, and that's a general statement for all rural areas in the United States. There's a rural mortality penalty. People call it the mortality penalty for living in a rural area. And the penalty is a result of deaths that occur largely from heart disease in the first place, unintentional injuries, COPD, lung cancer. There are very high rates of cancer, especially lung cancer in Kentucky and in many rural areas, stroke, suicide, and diabetes. The life expectancy gap between rural and urban dwellers is actually increasing. You could see it was only 0.4 years in 1969 to 1971, and it was up to 2 years in 2005 to 2009. It's actually increased. It's thought that these disparities are really related to the austere environment, the socioeconomically austere environment, and the impact of adverse social determinants of health. So people in rural areas deal with socioeconomic deprivation, a phenomenon called persistent poverty, which is different from poverty. It's a condition where poverty exists in the county or in the region for longer than 5 years unchanged. And it is a much higher predictor. The presence of persistent poverty is a higher predictor of all of these negative cardiovascular disease disparities that we see. There are a number of environmental barriers to health, and there's a very unequal distribution of health services in rural areas that contribute to these disparities. This is a picture that looks at, or a figure that demonstrates the impact of some social determinants of health. So we have Black race in the red, percent without college in the purple dots, per capita income in the yellow lines, percent poverty in the green line, and rurality, the percent in rural areas, in the orange line. And you can see the top 3 areas where these the highest mortality is the convergence of Black race, low education, and rurality. You get a better picture of what's really going on in these areas when you look at a situation where these investigators included the interaction of virality with poverty, and you can see the very high rates, and virality and poverty here is in that purple, that mauve color, huge increases in deaths from related to the interaction of virality and poverty. You can see that black race is still a big predictor, as is low education. So huge problems to consider with relation to the risk of mortality, and especially cardiovascular disease mortality. And I really just want to point out the impact of black race. So when I said that virality confers a mortality benefit, a penalty, a mortality penalty, there's an even greater mortality penalty for being black in a rural area. If you look at the risk of cardiovascular death in a black person living in the most, in the area with the least poverty, the higher rates of education, they still have worse outcomes than a white person living in the worst rural area in any county. So not only is there a rural mortality penalty, there's an especially strong black rural mortality penalty that really hasn't been addressed. This is, I just want to show some of the reasons why we see some of these disparities, and this is a great slide that shows what happens longitudinally when income changes and its relationship with cardiovascular disease. And this is from the ERIC studies. And you can see up on the left, those dotted lines are the confidence intervals. That green straight line is the risk of, or the hazard for mortality. You can see that it starts up high when the lower income, as income changes more, and it improves as income improves. This is a really nice demonstration of the relationship between income and cardiovascular disease mortality. When I was looking for slides to see how people talked about Appalachia and about the problems in Appalachia, I came up on this great site called the Appalachian Learning Initiative, and they have a little sign like this for every single county, rural county in Kentucky, actually in Appalachia. And they talk about the population, and then they list the many problems in the areas. People are underinsured. 37% in this county haven't graduated high school. 52% live below 150% of the federal poverty level. 81% of adults read at or below an 8th grade level in this area. And you can see on the right many other programs, and they really are many other problems. And they've highlighted this problem of literacy, adult literacy in Appalachian counties. You can see high rates of adults reading at or below the 8th grade level in the dark red and orange. And you can see some lower, you're getting better when you get down to the green, and I think there's like 2 poor little lone counties that have some of the green. So you can really see this problem of literacy in Appalachia. So I looked through all of these slides, and they have something for everything, obesity. And I thought, okay, now this place is going to know what to do about all this. But then I happened upon this slide because it said, here's how we fix the problem. And this was their slide, developing practical solutions. I thought, no, this has to be a joke. But they talk about it as a work in progress, that they haven't really identified the best evidence yet. So when we look at sources of rural disparities compared to urban populations, it's important to note that rural populations have higher poverty levels, higher rates of persistent poverty, fewer workforce options, higher unemployment rates, lower paying jobs, lower literacy, poorer access to healthy foods, and more food deserts. People often sort of look at me like, what, they can just go to the store? Well, if your store is 20 miles away and you don't have a car, you can't just go to the store. If you live at the top of a mountain and the road's snowed in, 30%, 40% of the year, you can't just go to the store. And when you go to the store, you might be surprised at what you see. So this problem of food deserts and access to healthy foods is really severe in Appalachia, many rural areas. There are a lot of environmental barriers to safe activity opportunities, and I was talking with some other folks earlier about, you know, people often say with this one too, what, just go have a walk? What's the problem with that? But if you go to Appalachia and you go to many of these areas, there aren't sidewalks. There's not areas that are flat where you can walk. They're actually not even safe. It's not like you're happily walking through the woods. There's streams and creeks and rocks and divots. And we commonly come upon this phenomenon where people have their mobile homes right next to the water, sort of down in a dip, and there's, you know, no place to walk around there. So kids put up basketball hoops because Kentucky is really, University of Kentucky is very famous for its basketball and everybody loves it. They put up basketball hoops in the road, and you have to be really careful when you're driving there because kids have to, you have to pay attention there. You're not going to run some kids over playing basketball. And it's very common because there is no place to safely play or walk. So it's a very common problem. There are much poorer housing options, lower rates of insurance, even though we think we're all, you know, supposed to have insurance now, and very higher rates of underinsured folks. Poor access to health care, all of these types of health care, and longer transportation times. It takes 2 or 3 or 4 hours sometimes to get to a place that can just provide basic care, let alone other sorts of care. So when I think about the solutions, and I've talked about the solutions, worked with people about solutions, the thing that becomes very important is the notion of community-engaged research. You really can't ever address a problem that affects a community into such depth as this problem in urban areas, in rural areas, anywhere, where it's really endemic problems, epidemic problems, without engaging the community. And so where you engage all the stakeholders, so that includes the patients, the non-patients, but the people living in the area who are susceptible to poor health, the healthcare providers, the business people, the church leaders, the people who own grocery stores. So we really have worked on developing a community advisory board that includes all of those people. We need to focus on problems and solutions identified by stakeholders. We need to do, with our community engaged research, culturally appropriate recruitment, follow-up and intervention, or everything you think you want to do is going to fail there. People are very suspicious in this area of researchers who come from universities, do some research, and then leave and never give back in any way. So you really have to avoid that problem, as we all should. We employ local staff and resources to provide, jobs. It's one way of providing jobs, but also in making sure that you have the right people to recruit folks and to do really effective interventions. And you need sustainability plans. Because just coming in, doing a project, showing it works and leaving, even if you're nice, is still a disaster if you don't, leave people with some of the solutions that they can engage with to solve the problem that you identified and you are like making a big deal out of. If you just leave, it's really inappropriate. I show this house here. I commonly put it in talks because it shows some of the problems that people face in this area. So as you can imagine, this house, it has like a plastic window. It's, it's not looking so good. And it has a light on the outside, but there is no light inside. There's no electricity in this house. And there's a little trailer to the side, to the right-hand side. So an older gentleman with heart failure lives there, and his son takes care of him and lives in that little trailer thing, but he has many problems himself. So these are some of the living environment and also some of the personal problems that are faced when you have caregivers who are sick as you are. You are in this situation being really ill ultimately and having very few resources. So community engaged research can really help this issue. Also, stakeholder engagement is essential. And I know you saw I was funded by PCORI, so you know how I got this stakeholder stuff down. Although a lot of people don't like this word anymore, stakeholder. So I don't know what they call it now, but anyway, I apologize if you don't like it, but it involves the engagement of people for whom the problem is really relevant. We have done focus groups with patients, care providers, and community leaders. We have community advisory boards that are convened before the studies are begun and held throughout the entire time, every month. Many of the community advisory board are co-investigators, paid co-investigators. Everybody who attends a meeting is paid. All of the staff are hired from the community of focus. Community health workers are engaged to do a lot of the interventions. We involve patients in the dissemination, which is really a powerful, powerful way to get the results out and get communities engaged in following the interventions or suggesting the uptake of interventions that you test. I talk about the first patient that I took following one of the studies that I'll talk about, which was very successful in reducing cardiovascular disease risk. I took him to PCORI with me, and I was presenting, and then he was presenting. And he had never been out on a plane, and he had very, very rarely even been out of his county. But he was wonderfully articulate and really excited about the opportunity and was so engaging. So I spoke first, and, you know, people were sort of, you know, multitasking, looking at their computers, doing all this. And then he gets up and he starts talking, and everybody just puts their stuff down and just stares at him because he was so engaging. And it's the story of how you intervene and how you're effective and how to keep it up. So this is really a powerful way. And he also did some dissemination in the areas that were affected. He actually was a great guy, and he put the group together that he was in with the intervention, got them to, do a little club where after the interventions, when they met during the week, they would walk up the hill to the super old church. No, that was the City Hall, which is a really old building, and it was a big old hill. But he would get them to, walk up there and start to do the things that we talked about were important to do. And they were all really interested in doing these things because they were from Manchester and Clay County, the poorest, fattest county in the area, in the United States. And they did not like that. And they really, as many people in that area, felt like they didn't have the resources or the skills or the expertise to engage in simple cardiovascular risk reduction. And so they were delighted to get this intervention, and they were really amazingly compliant with it. Finally, you need to understand the environment. And these are some pictures that shows you can see the number in the dark brown of households, percentage of households with no car who are greater than a mile to the store. And there's a huge pile of them in that eastern Kentucky area and West Virginia. There's a mobile home with not much around it. And this is one of the famous streets. I love this picture with see the sign there that says, it's the Ridge is the name of that street. And that is the street. So do you see the street? I don't see the street, but you drive down there. And you get sort of instructions like that. When we would go to people's homes, you get instructions to go down the Ridge Road or go up River Road. And what that really meant was get on the road in the river and drive up the river. That took a while to find because that was not clear. We just kept calling, and they said, get on River Road. River. You know what a river is? Okay. That was good. No. Oh, God, no. No. Not on Google. When I talk about also solutions, understanding community strengths is essential, and that sort of goes without saying, but many, many interventions are done without paying attention to any of the strengths that are known in the community. So in this area, as I said, we did a lot of focus groups, and people in this area have a strong tradition of community mobilization when awareness of a local problem occurs. We recruited more than 1,100 people to the study one of the studies I'm going to talk about in less than a year. And when I say that to people who do rural research, they're all convinced they're too hard to reach. And I always say, if you do right, and I'll tell you what right is or how we do it right, it's not hard because people really do want to address the problems. There's a real potential for homegrown change. People in this area are really open to, being part of the solution and being part of pushing novel interventions out there. People are very neighborly. There's concern for neighbors, friends, family, and community. There's genuine concern for the health of the community and willingness to promote change to improve it. There's a huge desire to improve health, and there's an interest in self-care, which is our own self-management on a daily basis, which you'll see in a minute is one of the things that I think is fundamental to intervening. And they have a recognition that they don't have the knowledge and skills that are needed to make a lot of these changes. So people are very, very open to this intervention. On the last day that we were closing out our study, there were people in lines, like 20 people in lines who wanted to be in the study. So we let them, but we didn't quite close it out then. But it's not the situation where when I interviewed a lot of the healthcare providers who were people who were sort of temporarily working there, who said things like, these people don't really want to change. They don't care. I'm not even talking to them about it. Why are you? And just a huge misunderstanding about what people need and want in these areas, that based on perceptions that are really misperceptions. Another important solution is to engage in self-care, teach people to engage in self-care. We all have to engage in self-care. 99.9% of our time is with ourselves, not with our doctors in a hospital, but by ourselves, taking care of ourselves. So we need to help people understand cardiovascular disease risk at an individual and a family level and the community level. So we teach people to know all their numbers, to know what they mean, to find out, be nosy and find out everybody else's. Understand goals that are relevant to the problems you face and set those and understand how to achieve them. Learn the skills to achieve the goals. Develop partnerships with other people, with healthcare providers, with businesses. Build on the self-reliance that's very well known and very characteristic of many rural people. And self-care in this area also involves a lot of problem-solving teaching. When I say understand the environment in which people live, this comes from this whole notion of what's called Lewin's equation, where behavior is a function of people in their environment, and they tend to adapt their behavior to the environment they live in. And so any kind of assessment of an environment is really essential when you're dealing with people and communities who are rural and remote. And I just have I want to point out the importance of this. We tell people all the time, just eat more fruits and vegetables. I mean, what's hard about that? Well, here's the grocery store in this area, and it looks like that. It's not just that people have shopped it out. It's that it never fills up. That's what it looks like. It might have a few more fruits and vegetables. Or they're shopping actually at the local grocery store, gas mart. There's no fruits and vegetables in there, trust me. So you really have to think about what you say when you tell people to just eat more fruits and vegetables and how you're going to facilitate that. Just buy frozen fruits and vegetables. Well, remember this fellow who lives here doesn't have electricity. He doesn't have a fridge, doesn't have a freezer. He's not going to buy frozen fruits and vegetables. And then this store, this was a pretty amazing store where we walked in. We often tell people to buy low sodium canned vegetables. They really are not available in a lot of these areas. There's no low salt canned vegetables, soups, or juices. There's few canned fruits. They were in heavy syrup. There's no frozen fruits. There's no skim milk. There's no low fat or low sodium cheeses. And this is the store when it's stocked. There's the stuff that you can buy. And we went into this store when we were assessing it. We walked in, and when you walk in, the only thing that's full are racks and racks and racks of soda pop. So not water, but soda pop, and then these really sparsely filled racks of canned goods. And maybe there's a freezer type, a regular freezer type frozen. And this is what people have to choose from. So another thing we say, let's talk about eating out. It's really easy when you eat out to choose more veggies. Well, Here's an example of a restaurant. So let me tell you that fast food is really popular in these areas because people living in rural Appalachia want to normalize. They're tired of being the poor, the fat, down in the hollers. They hate those, all of those things we say about Appalachians. And they want to go to the fast food place. So fast food places are actually really abundant in a lot of these towns. But this is what, try to get a fruits and vegetables at McDonald's, good luck. This is what a common, this was an eating place that we went to. It's that one that this one on the left. It's a restaurant there. And their special is a meat and 2 veg, and look how cheap it is. So people actually do go out and eat. But do you know what the veggies are? So we went and ate. There were 3 of us, and here is the food. There's fried shrimp was one of the meats, and you notice there's French fries and coleslaw. That's the veg. There's a hamburger with more French fries and that might be potato salad. But the whole idea of a veg actually being a veg, a discrete vegetable, is not in the thinking of this 1 meat and 2 veg. 1 and 2 or 1 and 3 is what they call it in the South. We need to think about understanding the people in their environment and how they react to the environment. And this lady loves to have us take her picture. She said, you can talk about me all you want. But she spent her first several minutes talking with the ladies who were research assistants who were enrolling her in a study, telling them, you girls are just stupid. You're stupid. It was like, oh my God, these poor research assistants. They're like 20 years old. They're wanting to back out of the trailer. But she was trying to say that, you're asking me to do stuff that's literally impossible. So she doesn't have a car. She lives by herself. She has, friends and family who maybe come, once a month. And she snowed in the winter. So everything we were telling her was ridiculous unless we adapted it. And also you have to intervene with sensitivity. And this is, you can see our heart health was the name of our intervention. And these people really took to it. This is a group of senior citizens where we really let them tell us what was wrong with their ability to engage in any cardiovascular disease risk reduction and how we could fix it. And that sort of interaction really resulted in the interventions that we do and the outcomes. So one of these very first studies that we did, we tried to determine if we addressed all these adverse social determinants of health, could they be overcome within a cardiovascular disease risk reduction intervention that was designed specifically for rural, socioeconomically distressed environments. We know that lifestyle interventions can reduce CVD risk by at least 40-50%. Lifestyle change is most effective when patients are given the tools to engage in self-care. And we thought that to be successful in this socioeconomically austere environment, that these interventions really need to focus on lifestyle change, but it has to increase the abilities of the individual to engage in self-care, and they had to be culturally appropriate. And they have to have components that overcome social determinants of health barriers. And that was the heart health intervention. And sometimes when I describe this intervention, I can see people's eyes glazing over going, oh God, another lifestyle intervention. But this intervention is very different in that it's designed to decrease each individual person's barriers and to also deal with community barriers and overcome a lot of the problems of these adverse social determinants of health that will, if unaddressed, will never let you be successful. Our specific aims were to compare the impact of the heart health intervention versus usual care on 4-month and 1-year CVD risk factor outcomes, and these were selected by patients. We had patients pick a goal, good evidence-based material showing that when you pick a goal, you have a better chance of achieving it. And then we also wanted to take these same risk factors and compare 4 and 1 month impact in those 2 groups on all of the CVD risk factors that we measured. So whether people had high blood pressure or not, whether they had high lipid profiles, I'll tell you a little bit more about that. Because the issue is in this area is that they are just rampant with cardiovascular disease risk factors. Let me see if I show my, so I'll get to that point in a sec here. We enrolled 352 individuals, randomized. They were at risk. It's a 2-group randomized controlled trial, and this design shows when we measured, and I talked about that, baseline, 3 months of intervention, and then at 4 months and 12 months. I include this inclusion criteria here to show you that you had to, first off, to be included, they could not have a primary care provider, or they hadn't seen one for more than a year. That was not difficult in this area at all. And second, they had to be at risk for cardiovascular disease as reflected by having 2 or more risk factors. So when I told you that and you see all these risk factors here, that we enrolled 1,100 people in a year, there was not one single person who did not have 2 or more risk factors. Nobody failed this inclusion criteria, which is really astonishing and very worrisome. Our interventions were standard of care, but we amped it up a little bit where we got an appointment with the people in this group with a primary care provider. They received free referral to that provider for management of any CVD risk factors that we identified in the screening, and they were given at free or low cost this appointment. But we didn't otherwise influence the delivery of care. We sent a letter that said, we're referring this patient to you. We identified these risk factors. You need to treat cardiovascular disease risk factors. We actually even sent a guideline about that. But otherwise, we didn't influence the delivery of care to be reflective of the reality of usual care. This heart health intervention and its many modifications since we've stopped, or since we've modified it for other studies, it includes multiple interactive modules. And interactive, I always put that. We engage people every moment of our time doing these modules. We don't just stand up there like talking heads teaching, boring people to death. We engage them with really, interesting questions. We pay attention to what they say, what they've done before, what their problems are. So in these major areas right here, it's delivered over 12 weeks, and we did groups of 10 or less. And we always include specific behavior change principles. And a lot of these are addressed down here. We dealt with the environment. We addressed low literacy in all of our interventions. They were skill-based. Promotion of self-care of cardiovascular disease risk factors, which works really well in an area where you don't have anybody to go to, even if you wanted to, for this sort of thing. And if you did, they have a tendency to not concentrate on these areas. We use subjective and objective measures for all of these risk factors for specific aims in 1 and 2. So we had a nice mix of subjective and objective measures. We used intention to treat convention. We actually, just to sum this all up, we used mixed models for repeated measures. And I'm not going to show you anything about this, except this is the flow of the consort diagram. Down at the bottom, you'll see an 82% retention rate, which is pretty good given any sort of long-term lifestyle intervention and especially a rural one. We had similarities between the groups in all of our baseline characteristics. These are more baseline characteristics in all of these things that would influence or confound the outcomes. They were similar at baseline. We were stunningly successful in getting people to meet their CVD risk reduction goals. So if any goal was met, it's at least 50% of people and 16% in the control group, because we gave them a goal too. Body weight, 36%, a body weight goal, which is to lose 10% or more of their body weight. 65% increased physical activity. 88% lowered their blood pressure, lowered their lipids, another 83%, and hemoglobin A1C. You'll notice that activity like smoking and depression are not on here, and that's because no one picked those as goals. No one in this really high smoking area picked smoking or depression management, because there's a huge, stigma associated with depression in this area, and people believe you should just get over it by yourself. And so they didn't pick that. But you'll see in a second that nonetheless, there were some impacts. We actually had an impact on decreasing smoking behavior based on urinary cotinine levels. So this is a nice objective measure. And we believe this happened because with the type of intervention we did was a whole health intervention. So it involves, good diet, physical activity, managing comorbidities, understanding the condition. So you could do this intervention to treat any of these risk factors. And we also have a depression management and stress reduction intervention. And we think that people, when they saw, oh my God, I can do this. I can eat better. I can be more physically active. I can actually, change my blood pressure. Some people decided to give it a go with the smoking. And you can see, and they got positive feedback from the people in their group and from us. So there is a really amazing long-term decrease in smoking behavior. Better lower body mass index in the intervention group. The Framingham 10-year risk score decreased. There were changes in systolic and diastolic blood pressure. The number of steps taken per day increased. Total cholesterol decreased. We didn't see a change in low-density lipoprotein, but did see one in high density. And importantly, depression scores. So I actually do a lot of research about depression and managing depression as a risk factor for cardiovascular disease, and this has always been in our studies, is management of depression as to decrease cardiovascular disease risk. And this area has huge preponderance or disparities related to depression, so it's important to manage. So we think that those interventions like that focus on self-care of risk factors and negative social determinants of health that are derived from collaboration with the community can be really effective. It was easy to recruit, there was high retention, it was very successful, and that these interventions might be well developed or adapted for other rural or medically underserved, socioeconomically distressed areas. Let me talk a little bit about sustainability, which is really an important issue in the long term. This intervention and its success, it was implemented then and is still ongoing at a place called Home Place, which delivers indigent health care. Firefighters adopted it in several areas as their yearly, they went through this training every year as part of, they have a yearly health training that they have to do. Several businesses included it and decreased the insurance rate for their employees if they joined in it. It was adopted in healthcare system in Eastern and Western Kentucky as part of the employee health program. People got local grants and local clubs really became involved. And the advantage of having we had the head of the Better Business Bureau in rural hazard. She got a grant to map out and develop safe walking areas in the town of Hazard, which is really stunning. Some of the negative sides, or the questions that we still have, are these, can we change policy that really is fundamental to the problems that exist in the first place? We can sort of override a lot of these problems, but fundamentally, this place is going to have persistent poverty forever if we don't do anything about it. The long-term impact is unclear for longer than a year, and that's something we hope to study. And it doesn't probably really address underlying problems in the long term. It addresses people's ability to deal with those underlying problems, but we need to work on those underlying problems as a community, actually as a state, as a people. These are long-term problems that have just existed forever. We did a similar intervention. I'm going to go really fast because I want questions. Not super fast, but this was for caregivers because the number of people providing informal care to a family member is increasing, and cardiovascular disease is a really big risk factor in informal caregivers. Cardiovascular disease as a consequence are present in higher rates in informal caregivers compared to non-caregivers. And those people are then still often really invisible to the healthcare system and policymakers. And rural caregivers are particularly at risk. So we developed the Rural Intervention for Caregivers Heart Health. We just finished this randomized controlled trial with multiple outcomes similar to the previous study. And let let me see if the design is the typical, 2-group randomized trial, stratified by male and female, since there are way more female than male caregivers. And this rich intervention was different in that it was a real-time video conferenced self-care CVD risk reduction. And this was really helpful because COVID was happening in the study when it started. And we proposed this in the first place because of the difficulties in getting people who are taking care of somebody else out of the home and in a place where they could get an intervention. And so we've since actually gone to this delivery method, and it works really well because we have wonderful, engaging interventionists. Very similar intervention to the one before. We gave people mini iPads in both of these. Usual care was the same thing. Here's a giant concert diagram, but the thing that I want to point out again is 85% retention. Really amazing. And just I only have some outcomes. I still haven't reported others, so I'm not going to talk about all of those. But with regard to adherence, you can see much better adherence across time and sustained in the intervention group, and much better, these are all indices of healthy eating, better in the intervention versus the control group, many indices. And the same thing with more. And an important point is no moderation by age. So regardless of the age, younger or older, this intervention was effective. I think it's an effective way to intervene with hard-to-reach anybody, rural people. We have another trial that's ongoing. The Combat DS trial is a comparative effectiveness study to manage depressive symptoms in rural people who don't seek care, can't get care even if they did seek it for depression. Because of its impact on cardiovascular disease. So we're studying cardiac patients with depression and using two different, a video conference with a live interventionist, CBT intervention, and then a self-run CBT intervention where you just go online and talk to the computer, but not a person. We're looking at these outcomes here, moderation of the intervention by social determinants of health and cognitive function. We're working on another trial of managing depression before you manage cardiovascular disease risk factors. And we're trying to turn parts of this intervention into an app-based approach. The interesting part here is that it's, done with motivational interviewing and stages based on stages of change, and you wonder who the heck is going to be the coach. Well, there's some amazing AI going on, and the coaching, or the people who are working with us to develop this AI coaching, are actually better. The AI coach is better at motivational interviewing than I am. So it's not like those stupid bots that you get on that want to chat with you and you want to kill them and your computer after 2 minutes. It's like this amazingly intuitive AI I was so against AI because of all these experiences and lying, ChatGPT, whatever. So, but it's just progressing at such a rate that this AI coaching actually might turn out to work well. I'm just going to have 2 more slides. I want to talk about resilience, and this is a slide that anybody can find anywhere. People are studying this, and it has to do with the county's ability to be resilient in the face of a disaster. So terrorist attack or environmental disasters. And in this case, what we're talking about, and you can see this part in the orange and the south, or not orange, in the blue, those are the dark blue, or the areas where resilience is low, meaning people in the area and the community will have great difficulty. And this is in 2 years ago, about 1.5 years ago, there was the worst flood in eastern Kentucky, which is where we do our work in history. It killed many people, 50-some people. It destroyed hundreds and hundreds of homes and completely destroyed the infrastructure in Hazard, that place I've been talking about. There's, no internet, there was no pharmacies, there's nothing that, the grocery stores are ruined, all the businesses are ruined. And it is a consequence of probably global warming and poor management of natural resources around the area. But I wonder about any impact that we'll ever have when we're faced with these sorts of disasters in increasing numbers, Kentucky is like, as other states, it's not just Kentucky, faced with endless disasters that destroy these super marginal areas anyway. But people still want to live there. So what are we going to do, as a community, as a healthcare community, as a nation, to, resolve some of these issues so that, although this wasn't a simple flood, it was a flood that many people, want to recover from and do recover from. But in those areas with that low resilience, that's not going to happen. They'll go back and live here, but in even worse circumstances. So let me finish with questions. If you know kudzu, that's it. Covering up all the problems, looking lovely, but wreaking havoc everywhere. So please, any questions?
Okay, well, thank you.
Thank you.
And lots of questions, actually.
Great.
Let me repeat the CME code for people at home in particular. 50121, 50121. Certainly welcome questions from the audience here. And let me just start off with a factual check. One astute viewer notes, what happened between 1992 and 1994 that there was such a large jump in the death rate? Is there a new definition of some sort?
No, it probably was. I should have mentioned that because I notice it too. I notice it every time. But a lot of people think that it had to do with better, actually, just chronicling of death rates. So, and that was that cardiovascular disease death rates or no? It wasn't. So it just was probably better record keeping. That's what people think.
Okay. Dr. Irwins?
Yes. Hi. I enjoyed your talk. Have you tested any financial literacy interventions? Because one thing I've noticed is that healthier lifestyle tends to save money, and seeing the money accumulate in the piggy bank can be an incentive.
Yep. So we use a measure of health literacy and base our interventions on health literacy. And a lot of the motivational interviewing that we do talks about achieving those sorts of goals. People, it's based on what people say their goals are. And they say things like, I can't get sick anymore. It costs me too much. And so we do include that, but it needs to be more intentional. I think you're absolutely right that it's a goal that many people want to achieve, and if we were more intentional with it, I think it would be effective.
Thank you.
Thank you.
Thank you, Dr. Mosher, for our lovely talk. I'm interested in discovering if you do you have much in the way of race differences in your data? Is it mostly white?
In this area, Appalachia, Kentucky, is mostly white, and you may have seen that one slide. And it's, resulted in our drive in the next studies that we do. You notice the richest study. We are going to stratify by race so that we include at least 50-50. So we over-enroll by different races other than white, and we want to do a good black and white comparison just to have enough people to make conclusions about the effectiveness of interventions. And it's, an area that's been neglected by us and everyone because they all say, there's only white people living there. Well, that's not true. And there are many other areas of Appalachia that are heavily black, and we just have really increased our ability and our thoughts about doing that in all subsequent studies, having much more diversity. Great question.
Thank you.
Hi.
Hi, Dr. Mosher. Thank you so much for your talk. Tiffany Powell-Wiley at NHLBI. Can you talk a little bit about any efforts that may be happening to combine or to bring together urban community advisory boards with rural community advisory boards? A lot of the things that you brought up in terms of assets are things that we talk about in our community-based work. I'd love to hear your thoughts on it.
I think that's a fabulous idea because you really point out the obvious that's, food deserts exist in urban areas, horrible food deserts, or, inequity in what's in a store. A Walmart in a lower income area doesn't have the fresh fruits and vegetables in a higher income area. And in fact, they're more expensive where we live. It's just sort of shocking. But so many of the same problems, no safe place to exercise, scared to go to the doctor. The doctors aren't in those areas, or the healthcare providers often. And so I work with Dr. Lavora Williams, and she does similar, but she concentrates on prediabetes, and she studies Black people with prediabetes. And I'm a co-investigator on her grant, where she has this fabulous community advisory board. She does her work in churches, and it's in towns, not rural. And I have really thought about working with her, trying to work with her to combine those community advisory boards, because patients are such an incredible source of, not just patients, the people who live in the areas are perfect. When I first thought about having a community advisory board, I just thought, oh, good Lord, what are they going to know? Well, in fact, I'll be honest, that's what I thought at first. But, after one meeting, I realized they actually know everything. And we really need to talk to them and figure it out. So I work with Gia Mudd, Dr. Gia Mudd. She does work with Hispanic people. She has a fabulous community advisory board. And all of us, put together could come up with some great solutions that cross all these areas.
Thank you so much.
Great point. Thank you.
Alan O'Malley from Heart, Blood. I enjoyed it very much. I have two related questions. Is there a need for perhaps more intense interventions? And if so, could imagine in the general population, adherence, compliance, for example, with statins is terrible. And whether that's an issue as well that needs to be addressed.
It is. And we have been, I would say we're very lucky, because we were really successful in getting interventionists and recruiters from the community. And that was a great way to keep compliance with the intervention up and keep engagement in the intervention up. We have a stunning interventionist who is from, rural Kentucky. And she's a psychiatric nurse practitioner with expertise in cardiac. So I have kept her for 20 years, and I hope she can move with me when I move. She is so engaging and so perfect. And it worries me that sometimes these successful interventions of ours are interventionist dependent. So we've tried to, sort of bottle her and figure out the characteristics of being a great interventionist. And it has to be empathetic, you have to be engaging, you have to be willing to carry on conversations that appear to not be related to what you're talking about at all. But I think we're going to discover that in the long term, even though we had these 12-month impacts, that we are going to have, more intense interventions that you have to intervene, you have to get in there year after year, I think, to see any sort of long-term success. And any of these less intensive interventions that we try. So this was a multiple cardiovascular disease risk interventions. And even these single-focused interventions are not often successful. So you can imagine trying to maintain multiple cardiovascular disease risk factor reduction is difficult. So I do think more intensive intervention is needed.
Yeah, I was thinking in terms like primary versus secondary prevention, whether you have a
God, yes.
But you answer my question.
No, perfect, yes. And we're doing some work with grandparents who are, they would be secondary usually, but we also are trying to do some work in schools. Harder just because of, rules about getting into schools, but the perfect place to really do this kind of work. Thank you for clarifying that. I'll answer any question, even if you didn't ask it. I'll answer it.
Dr. Mosher, thank you very, very much. Clearly, this has been a very interesting topic that's led to a lot of engagement. For those of you who are here at Lipset, you are welcome to join Dr. Mosher and the rest of us. We're going to have a little reception time outside. For those of you who are on videocast, thank you for joining us, and we were so glad to have you here.
Thank you. I really appreciate it. Thank you. It was great.